Welcome back to Mayo Clinic Radio. I'm Dr. Jake Strand.
And I'm Tracy McCrae.
As a physician and health researcher, Dr. Rozalina McCoy has often counseled patients on avoiding unnecessary testing and treatment. Dr. McCoy was doing her part to help patients keep costs down by avoiding low-value tests. It's an easy thing to preach, but as Dr. McCoy has come to find out, not so easy to practice.
Yeah, last year, Dr. McCoy was diagnosed with Hodgkin's lymphoma. And during her own cancer journey, she has gained new understanding about the fears and worries of being a patient. Here to share her story is Mayo Clinic primary care physician, Dr. Rozalina McCoy. Welcome to the program, Dr. McCoy. It's nice to meet you.
Thank you so much. It's great to be here.
So just last year, you were diagnosed.
Yeah, I was diagnosed right after Christmas. Between the Christmas week and New Year's week was a great way to start the year. But it also meant that I got to welcome this year all healthy and cancer-free. Knock on wood.
How did you present? How did you get sick? How did it all start?
I think like many patients, I just noticed that I got really tired. And in retrospect, it probably started about a month before I presented, but you always attribute it to little kids and work and a 10-month-old and a 2-year-old and being busy overall. But I think when I got to the point a month into it of going from running a 7-minute mile, 6 miles a day, to not being able to go up a flight of stairs, I said, it probably is not a virus.
Hold on a second. How is this buried in the lead? You run a 7-minute mile before this happened?
Used to. I worked up for it after baby number 2.
Oh my gosh, I'm totally impressed.
I never got that. Not that fast.
I'm at about
That's
11 and a
impressive.
half. I could never keep up with you. Okay, so you started feeling tired. And how were you diagnosed?
So I ended up speaking with one of my colleagues, another primary care physician. I just explained that I am exhausted. I can't do anything, can't get up, can't shower. I'm not just tired like we all are. And I felt like I had to make excuses, probably like all other patients, that really believe me, something is wrong. So she ran a whole bunch of tests, blood work, and the only thing that came back positive was CK, so marker of muscle breakdown. And they ended up telling me that I have dermatomyositis. I went to see rheumatology, who said, well, just pro forma, we should do a CT scan. You know, you're young. This is going to be just isolated dermatomyositis, not like older people in whom there's a cancer underneath. At that point, I mentioned, by the way, I've got this lymph node that grew from nothing to about 10 centimeters. Maybe we should biopsy that. So we did the CT scan and ordered a neck ultrasound and biopsy. And on the CT that evening, we saw lymph nodes everywhere, masses everywhere. And when I was doing the ultrasound, which was the following day, I know how to read neck ultrasound. So when I looked at my neck, I was like, okay, that's going to be a lymphoma. Nothing else looks like it. And one of my colleagues was doing the biopsy, who knew me from when I was a fellow. He's like, yep, that's going to be Hodgkin's. So it was pretty much my way to be diagnosed. It was actually good because after the CT scan, my husband, who was reading up about dermatomyositis, said, oh, you probably have ovarian cancer.
Oh, boy.
So this was much better.
Yeah, take Hodgkin's anytime over that. So, Dr. Strand, there's 3 of us sitting here at the table, and 2 of us have had Hodgkin's lymphoma.
You kind of don't want to say about the odds, because that's just, it's an incredible coincidence. And also just to be then able to have this conversation, because there's, as I think we were talking before we started, there's a lot that's changed since with Hodgkin's treatments, and yet there's a lot of, I think, similarities. And so it's interesting. I'm curious, as you talk through this, what was your perspective as you thought through, you've taken care of a lot of patients who I imagine have come in with complaints about fatigue and want tests done. And so how did you kind of think through the way you talked to those patients and how you were talking to yourself?
I mean, I think the first thing, I think it probably led me to come in later than I would have, because I discounted it and I did not want to be the patient who bothers my doctor. Then when I was there and something actually was wrong, I actually was somewhat proud of myself, because I think I never discounted, and I hope I never discounted my patients when they came to me and they said that they were tired. I feel like every single patient complaint deserves one thorough evaluation. If you've had that and nothing changed, I think it's different. But every person deserves to be taken seriously. So I was proud of myself for doing that. And now I'm even more cognizant of that. I think I spell it out to patients to make sure they realize that I am listening. I'm not discounting what you're telling me. And this is what I'm recommending, and this is why, and that's why it is what you want. And if it's not, please correct me. So I think that was very helpful.
Tell us about what it was like for you as a physician to be diagnosed. I mean, I'm sure you go through the same emotions that all of us go through when we're diagnosed, but is there even a little bit more because you're a physician?
Yes, I think so I'm a primary care physician, and I specialize in diabetes management. I'm not good with cancer treatment, other than my residency. I haven't done anything with hematologic or malignancies. Hodgkin's is rare. I have never had my own patient with it. So I made a conscious effort not to read the primary literature while I was being evaluated and diagnosed. I told my husband, you do it. You make sure everything is done right. And that keeps him less stressed when he can be busy and reading things and doing the logistical things. So I think that helped me not worry and not think about all the other things that it could be. It helped that I have incredible trust in my hematologist. She's a wonderful doctor, and I'm extremely grateful for her putting up with me. But at the same time, I think because I was a physician, I knew how busy everyone is. I didn't want to bother them, so I kind of laid low, I think, a little bit.
So as a physician, one of the things that you are trying to do through your practice is help patients keep costs down with the low value tests. And then you become a cancer survivor. And now you have to try to find a balance of those two. I'm sure that has changed a little bit, the way that you view that whole decision.
Yeah, I mean, I think initially, even before my research, it wasn't just about the cost. I think with diabetes in particular, the reason for a lot of my work was to show that over testing, yes, it costs money, but ultimately it causes problems to patients, right? It can cause you to be overtreated, to have things done that aren't necessary, and ultimately that can lead to overtreatment and land you up in the hospital for no good benefit. So it wasn't always about the money, but it was one of the things that I kind of told patients that, well, it's just not worth the money that you pay for it. And now I realize that that's really not a good argument, and it can come across as saying that, well, you just don't think my needs or my concerns are worth it to you. So I think costs are important on a bigger level, but not to the individual patient, because that's not why we make our decisions as physicians. So why am I saying it in my justification?
Well, you described me earlier. You described a really nice example of when somebody comes in and you're talking through, here's why I'm doing what I'm doing. I want to know your opinion. Really outlining that model of shared decision making. And I'm wondering, is how you do that, has that changed a bit now, having probably gone through it with part of your cancer care?
Yeah, so I used to be I think I still am a firm believer in shared decision making. But I think my idea of what it is very different. So I used to think that it's about me giving patients guided options and helping the patient decide. And I think that puts too much weight on patients, especially in the acute situation when it's not a chronic disease where it's the same decision every single time, but it's something that they don't know anything about. When I had to face the decision, for example, midway through my treatment about whether to continue bleomycin, one of the drugs, or stop it after 2 months, it was sort of given, this is the data, what do you want to do? And I'm like, well, I want to live, so you tell me what to do. And I think that exemplifies why the pitfalls of shared decision making. So now I think I try to tell patients, these are the options. This is the rationale for each of the options. I think this is what is most aligned with what you want to do because such and such. Does that sound right?
Yeah.
Because that takes the weight off of patients. I mean, some people, and it gives them the opportunity to either say, no, it's not what I want to do, or thank you for making the decision, or whatever is that they're more comfortable with at that time.
We have about 30 seconds left. How is your health now? How are you doing after the fact?
I think I'm good.
Again, knock on wood.
Knock on wood. Hope to be here in many, many years.
Excellent.
We're getting close to 7 minutes a mile. That'll be another good marker.
Yeah.
Well, we've been talking with Mayo Clinic physician Dr. Rozalina McCoy about her own cancer journey and how it changed her perspective in helping patients cope with life-threatening diseases. Thanks so much for joining us, Dr. McCoy.
Thank you.